Okay, welcome to this month's Center for Spirituality, Theology, and Health, Spirituality and Health webinar. I've placed everybody on mute, but you can unmute yourself at any time. And when we get to the question and answer period, towards the end of the talk, probably around about 15 minutes before we end, feel free to unmute yourself and then ask your question. So that's the way we'll work it today. I'm Dr. Harold Koenig, and I'm now going to introduce our speaker, Dr. Donna Ames. Now, Dr. Donna Ames is a good friend of mine and colleague, and we have been doing research for the last more than 5 years there at the Los Angeles Veterans Hospital there, that she manages all of the research projects there, and hopefully she'll talk a little bit about our current randomized controlled trial that we're doing there. And so Donna has been a psychiatrist serving veterans for the past 30 years, and she's been doing research for the last 40 years. It's hard to imagine that, since Donna seems so young, that she 40 years of research. But in any case, over 100 publications about medication treatments and side effects. She's been worked on inpatient psychiatry for almost 20 years and is running outpatient programs as well. She's a professor in the Department of Psychiatry at UCLA and has been a teacher and mentor for many people. She continues to do that today. And as I indicated earlier, we've been doing a lot of research developing scales and interventions for the treatment of moral injury now, for about the last 3 to 4 years. So Donna's going to be talking today about holistic and spiritually integrated approaches to the prevention of suicide and the treatment of moral injury in veterans with PTSD. So, Donna, why don't you take it away and then share your screen, and so we can follow along with your with you on your PowerPoint.
Well, pleasure to be here, everybody, and quite an honor. And my research journey has been very interesting, and I'll share that a bit with you as I go over this talk today. This is my disclaimer slide. The views I express today are not necessarily the position of the Department of the VA, United States government, and these are my funding sources for my research. As Dr. Koenig mentioned, I've been a doctor at the VA hospital in West Los Angeles for 32 years, and I did do research since I was your niece's age, probably, as an undergraduate in college. So I had like 10 years of research even before I became a professor at UCLA and started seeing patients at the VA. And I think what drove me into the field of psychiatry at 15 years old was that my friend committed suicide. So I was really determined that I wanted to be somebody who could help prevent that from happening to anybody. And the problem of suicide is huge in our society. This slide shows a picture about a movie that was very meaningful to me. I actually met the two gentlemen that are in this picture. They're on motorcycles together. They gave a screening of this film. The film is called Project 22, and they made it in about 2013-14. And it's about the high rates of suicide amongst people, our veterans in our country. And one of the fellows on the motorcycle was about to shoot himself in the head with the gun when he called his friend, and his friend really helped him, and he did not kill himself that day. But the other thing is that the movie shares that many people who suffer from PTSD really don't get better necessarily with current treatments. And these gentlemen decided to make a movie, and they got on their motorcycles and went cross country to raise awareness of the very high level of suicide amongst veterans and the different kinds of alternative types of treatments that might actually help people with post-traumatic stress disorder other than medications. So as Dr. Koenig said, my research originally in my life was focused on medications. As a psychiatrist, I saw myself as a psychopharmacologist, and I was very interested in treating schizophrenia. And I saw schizophrenia as like a cancer, an untreatable illness. And in my own journey, I learned that medications alone don't treat schizophrenia. And so we'll talk a little bit more about that. And medications alone don't treat PTSD. It's not even the #1 treatment recommended by the VA for people with PTSD. In addition to veterans having very high rates of suicide, the number's about 20 nowadays. Doctors have very high rates of suicide. And this was some data from physician on physician suicide. Roughly one physician a day kills themselves. And physicians make up a very small part of the population compared to veterans. So we have a really significant problem that doctors are killing themselves too. And there can be many similarities between doctors and people in the military. If you think about it, some of the stress that we go through and some of the training and the various pressures of being a physician as well. So as you hear about this research we're doing on veterans, I also want you to think about how it relates to doctors and physicians. And I'm hoping that everybody here is taking care of themselves during a very unprecedented time in our lives. And we all have to take good care of ourselves and reach out to one another, just like that one veteran reached out to his friend. If you know a doctor or friend who's suffering, reach out to them. It's very important. So there was a recent article published on religious service attendance and deaths related to drugs, alcohol, and suicide amongst US healthcare professionals. And I found this article intriguing because it suggested that religious service attendants protected against deaths from despair, from suicide, from alcohol. And this was a very interesting picture that I saw on the internet, that suicide surpassed war as the military's leading cause in November 2014. This came out of the most recent Veteran Suicide Prevention Annual Report that showing the different trends in suicide from 2005 to 2018. And this line, this dark line, are the youngest folks, the guys 18 to 34. And here is 55 to 74. This blue line is 75 plus, and this dark spotted line here is 35 to 54. I was really struck by the high suicide rate in this youngest group of people. And I wanted to contrast that suicide rate to this slide, which came from the Pew Foundation on religious service attendants. And if you notice, the millennials born 1981 or later, and this slide is from about 2010, so it's probably even different now. There's about 18% of people in the millennial generation going to religious services. And the greatest generation, the generation my mom and dad are from, mostly my dad, I guess, is 56%. So you can see the younger folks are not going much to religious services. And what did we see in the previous slide? The younger folks are killing themselves. I'm not saying that's a direct causation, but we do know when we think about suicide risk that having religious practice, having a sense that there's something bigger than you, that something meaningful in your life, a higher power, I think that's very protective. So these are some of the challenges of treating chronic PTSD or post-traumatic stress disorder. There's certain evidence-based treatments that are available, but a lot of veterans don't engage in those treatments. There's a big dropout rate. There seems to be an emphasis on what's called trauma-based therapy, which is like prolonged exposure, or cognitive processing therapy. They're not well accepted by the veterans. So we see that people drop out, and they're only 12 weeks long. Is the treatment of trauma going to get all fixed in 12 weeks by any kind of therapy? I mean, that would be a really amazing thing. And my thought is that when we're dealing with trauma, when we're dealing with any serious mental illness, we have to take a holistic approach. And the VA has mandated something called the recovery model for serious mental illness. And the recovery model, it embraces the notion that people with serious mental illness can live a meaningful life. They can do meaningful things. So unlike the notion I had when I was doing psychopharmacology research on schizophrenia, what I learned was people with schizophrenia don't need just meds, they need purpose too. They shouldn't be shunted into what we call in the United States boarding care homes, where they sit around smoking cigarettes and drinking Coca-Cola. So people with schizophrenia can live meaningful lives just like somebody with diabetes can. People with PTSD can live meaningful lives as well. And it's very important to realize that and to work with people on what is it you want to do with your life when a person walks in your office, and help them move forward with their life. Mental health recovery is a journey of healing and transformation, enabling a person with mental health problems to live a meaningful life in a community of his or her choice, striving to achieve his or her full potential. The recovery model is a little different than the medical model. The medical model tends to be a top-down model where the doctor says, this is what you need to do to get better. The recovery model is more collaborative, and this is the working definition of recovery. It encompasses hope. It's person-driven. What does the veteran want to do? What does the person want to do? There's many pathways to recovery. It's holistic. There's peer support. People who have lived experience of a mental illness can help other peers. Just like the key to that man not killing himself that day in that Project 22 movie was calling a friend. Everybody should have one friend in their life, a peer who understands what you're going through. Relational, culture, and recovery addresses trauma and strengths of a person, not just what's wrong with them. You want to know what's right with them and build on those strengths. So I believe that recovery in a holistic approach has to be biological, psychological, social, and spiritual. And I don't think in my own journey in my life that I would have ever thought that the spiritual was very important. I was a brain person, and I thought if I give these people the right chemicals, they're going to be fine. But now I'm a different person, and my own journey in my life made me really realize how important God was for me. And so I've been through a lot of rough stuff, and I wouldn't have gotten through these things without God in my life. So I realize now more than ever that we're not just a bunch of chemicals. we're spiritual beings having a human moment. And so when I meet with a veteran, we developed this thing called a personal recovery plan. And we ask the veteran about what is meaningful to them, what do they want to do with their lives, and we work on their goals in recovery. And we published this personal recovery plan, and we used it in a number of surveys by the Joint Commission and the certification bodies here in the United States, because they want to see that we're helping mentally ill folks move forward with their lives, not be stigmatized, not be chronically, like I said, in abortion care or chronic outpatient day treatment programs. Those don't even exist anymore at the VA. All day treatment programs have been turned into psychosocial rehabilitation recovery program. Along my journey of helping veterans, one of the things that I discovered early in my career was people on antipsychotic medications gained a lot of weight and developed diabetes. So we were amongst the first people in the world to recognize that. So I felt it was really important to get people to do healthy things for themselves. And I spent about 10 years researching exercise and nutrition programs and developing them for seriously mentally ill. But along that journey, I realized losing weight is a lot more than just exercise and nutrition. And I read this position piece by Roger Walsh, who said that these 8 things have a huge evidence base for well-being in human beings. And that psychiatrists should be prescribing these 8 things. And that is what I do in my practice. And I develop a little diary for these 8 things: exercise, nutrition and diet, time in nature, relationships, recreation, relaxation and stress management, religious or spiritual involvement, and service in helping others. Now, this gives me an opportunity in developing a therapeutic lifestyle change program with patients to explore with them where they are in their religious or spiritual journey. Some of them will say to me, I am not religious, I am not spiritual. So then I say to them, okay, well, what gives you purpose and meaning in your life? So we'll use the term purpose and meaning, because when you have these 8 things going on in your life, what we learned from our research was that veterans had better well-being, their blood pressure decreased, as a marker perhaps of like sympathetic nervous system being calmer because you're doing these 8 things. We did some research that showed the more of these 8 therapeutic lifestyle changes patients did, the better their well-being. So we published some preliminary data on the TLC approach. And I can say now, I work in a clinic and I have about 700 outpatients. And it is my habit to go over these 8 things with them. And the patients say to me things like, I can't believe I wish I met you 10 years ago when I got put on all these medications. And I say, well, you know, Thomas Edison said that the doctor of the future will use no medication. He'll use food, he'll use nutrition, he'll use the exercise and the care of the human frame to help with well-being. And so food is medicine. Exercise is medicine. I know if I don't exercise, I start to feel blue. Religion and spiritual involvement, so important. So in my journey of my clinical work, I started working with a chaplain, the head chaplain at the VA, and he mentioned to me that Dr. Koenig had inquired if somebody could help him with some research. And Dr. Koenig was trying to look at something called moral injury. And it was a new concept to me. This was about 6 years ago. And I told the head chaplain I would help with the research. And so Dr. Koenig, this is his model that he initially started with that I really find resonates with many, many people when I show them this very simple model. That people have not just post-traumatic stress disorder, but they also can have this moral injury, which is like a soul injury. And again, in the movie Project 22, one of the veterans very poignantly says, my soul was totally injured in battle. So what things arise, what things cause a moral injury? Killing, violence to others, witnessing violence, not protecting another person in battle, put in a morally compromising position. And then the moral injury is a sense of inner conflict. That's another way to think about it. And the person experiences guilt, shame, self-condemnation, feelings of betrayal, difficulty forgiving, loss of trust, meaning, hope, spiritual struggles, and even loss of faith. The mental health outcomes can be PTSD symptoms, depression, anxiety, substance abuse, sleep problems, relationship problems, and pain. So Dr. Koenig's theory is that if we can help people who are interested with spiritual resources, that might help with this problem, the spiritual struggles, the loss of faith, and it may also help with all of these subsequent problems that come from the moral injury. This is an example of moral injury that is used in laboratories to try to figure out what's going on inside the brain of somebody who's facing a very difficult decision. It's called the trolley dilemma. And in this picture on the left, this man has a lever and this trolley is coming. So he can choose to switch the lever so it only kills one person versus killing 5 people. Do you see how this might be a decision that might happen in a military combat situation? Do you see how it might be a decision when you're at war with a terrible illness and limited supplies in a combat situation in the medical world as well? This is another demonstration of the trolley dilemma, where the person is asked to deal with the fact that this trolley is coming, it's going to kill these 5 guys. But if you push this large guy over here, he will protect the 5 guys, but you're going to kill him. Now, people had less problem with the moral dilemma of just touching a lever than actually pushing somebody off a trolley. And there are researchers looking at what happens to the brain when you're dealt with these kinds of ethical issues. So these are some definitions of moral injury: perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations, a betrayal of what's right by someone who holds legitimate authority in a high-stakes situation, and a deep sense of transgression, including feelings of shame, grief, meaninglessness, and remorse from having violated core moral beliefs. So moral injury may actually relate, as I mentioned, may relate beyond veterans to civilian populations. It may relate, people might feel a moral injury if a child dies. Women might feel a moral injury about having had an abortion. Abortion doctors might feel moral injury about having committed an abortion. So euthanasia as well. Moral injury is not post-traumatic stress disorder. Persons with PTSD may also suffer from moral injury, but persons with moral injury may not necessarily have all the symptoms of PTSD. And the presence of moral injury may complicate recovery from PTSD. So PTSD, post-traumatic stress disorder, is associated with a traumatic event, intrusive thoughts, avoidance, negative thoughts about yourself, and increased arousal. Moral injuries associated with shame, guilt, betrayal, moral concerns, and spiritual distress, as we described before. And I think there's some overlap with moral injury and negative cognitions in post-traumatic stress disorder. Also, I teach anger management at the VA. I'm trained in evidence-based social skills training, and I teach a lot of veterans who have severe anger issues. And it's my thought that moral injury accounts for some of the anger that we see in these veterans. There's some scales that have been developed to look at moral injury that are listed here. Events and symptoms, and then symptoms only. Dr. Koenig's scales that he's developed are the moral injury symptom scale, the longer scale, and the shorter scale that I've helped him with development. And I believe Dr. Koenig's been involved with this scale development as well. So these ones, the moral injury event scale is commonly used, was developed by Nash et al., and that's to look at events. So let's say if you're treating something, you want to see if it gets better, you need a scale that will measure improvement over time. And since moral injury is a rather new concept, and to give you an example of the newness, I went to the American Psychiatric Association and gave a talk in 2019. There was only one other talk on moral injury, and that was Dr. Nash at the whole place with like 30,000 psychiatrists from around the world. Psychology is more up on the term moral injury, and I believe chaplains at our VA are much more up on the term moral injury and are really aware because of the spiritual struggles that people have. The chaplains are really tuned into moral injury. So this was how we developed the moral injury symptom scale. We worked together with Dr. Koenig and several other sites. 570 surveys were done.
Koenig.
I'm sorry? Okay. There was, when we gave out this scale, we noticed that there was a high level of interest in veterans to get treated for moral injury. And there was good validity and reliability for the scale. We also, I'm very pragmatic. I have 700 patients. I see one patient every half hour in my clinic. I need something that's short. So I asked Dr. Koenig if we could come up with a shorter scale. So he came up using statistical method of, I believe it was principal components analysis. Dr. Koenig, you can correct me if I'm wrong, with the items that would be most salient for this scale. It might have been discriminant analysis. But anyway, this scale turned out to be really is a really good one for a quicker way of assessing moral injury in my clinic. And we are using this in our current research as well as the longer 45 item scale. These are the items on the short scale. I feel betrayed by leaders who I once trusted. I feel guilt over failing to save the life of someone in war. I feel shamed of what I did or did not do during this time. I'm troubled by having acted in ways that violated my own morals or values. Most people are trustworthy. A person with moral injury will answer that negatively. They will have problems with trust. I have a good sense of what makes my life meaningful. I've forgiven myself for what happened to me or others during combat. All in all, I'm inclined to feel that I'm a failure. I wonder what I did for God to punish me. Compared to when you first went in the military, has your religious faith since then weakened or strengthened? And that's something that we ask the veterans. So another thing that I was curious about and asked Dr. Koenig to help analyze, and we wrote a paper on this, was the risk of suicide and moral injury symptoms. And we found that there was a correlation between suicide risk and moral injury. Another thing that we looked at was the relationship between spirituality or religiosity and moral injury. And so from this survey project, there's been several publications, and what we found was that in 90% of veterans with PTSD symptoms, they reported moral injury symptoms as well. So it's really important if you're treating somebody with PTSD to screen them for moral injury. And we found that religiosity was inversely related to moral injury in veterans with severe PTSD. And it was also positively correlated with post-traumatic growth. Another paper that was written, and I should have the reference here. Okay, Yusuf et al. They looked at whether veterans would prefer treatment from a chaplain or a secular therapist for moral injury. And 80% of veterans were actually open to spiritually oriented treatment. And then that also might be if a doctor, a psychiatrist, or psychologist wanted to explore using the person's spiritual strengths, that could be a way to help the patient. So there's been several specific interventions in development for moral injury. And the ones that we're working on are the spiritually integrated cognitive processing therapy and the chaplain intervention. And there's several above: the adaptive disclosure, impact of killing, acceptance and commitment therapy, and building spiritual strength, that are also being explored for the treatment of moral injury. The spiritually integrated cognitive processing therapy has been developed by Dr. Koenig and Michelle Pierce, and it takes cognitive processing therapy, which is the accepted standard treatment for post-traumatic stress disorder, and it integrates into the treatment the patient's spiritual beliefs and practices, rituals, values, and sacred passages to challenge and change unhelpful patterns of thinking behavior. Right now, we're doing a research study to see how this works: spiritually integrated CPT, cognitive processing therapy, versus standard CPT, versus a novel chaplain intervention that Dr. Koenig, myself, and a number of chaplains in our research team have contributed to developing. So the idea behind focusing on moral injury is that if you treat the moral injury, the post-traumatic stress symptoms may go down. With PTSD and moral injury and anger, your sympathetic nervous system is like revved up. And so if we can have people feel better and come more to peace with themselves about, the things that they've done in the past, I think all of those symptoms are going to come down. So with the spiritually integrated cognitive processing therapy, Dr. Pierce and Dr. Koenig developed 5 religion-specific appendices. So a chaplain or somebody in a church or other religious institution can use these different appendices to help somebody suffering from moral injury. The other thing that we're testing is the structured chaplain intervention for moral injury, and it parallels the cognitive processing therapy in that it's 12 weeks, it's 50 minutes, individual one-on-one pastoral counseling, and it's the interventions and the research we're doing is targeted for people who are religious or identify as being religious. There's modules within the chaplain intervention that deal with these, that follow this list here: conviction, lament, repentance, confession, forgiveness, reconciliation, atonement, recovery, and resilience. And anger is an optional part of it. What we do is we ask the veterans, what they want to focus on in this intervention. And we assess them. The chaplains are assessing them at each week to see which what dimension they want to focus on. So these are the 10 moral injury dimensions that are the content for the sessions in the chaplain intervention. Guilt, shame, betrayal, moral concerns, loss of trust, loss of meaning, self-condemnation, difficulty forgiving, religious struggles, and loss of religious faith. This is some data from our first person in our study. And the chaplain does the PTSD symptoms rating scale called the PCL5 and the moral injury symptoms scale at each session. It's a self-report scale. And as we theorized, we thought if we deal with the moral injury, perhaps the PTSD symptoms will come down. The chaplain's not dealing with PTSD, he's dealing with moral injury. And if you notice, the blue line is the PTSD symptoms coming down, and the orange line is the moral injury symptoms. Another study that we are working on is we're trying to help people in Los Angeles who are in faith-based communities to find out what more we can do to help them in dealing with veterans who are in distress, who are facing, such distress that they might be contemplating suicide. So we've recently conducted 2 focus groups with 10 faith-based leaders, and are now in the process of collecting resources to provide to faith communities to help connect veterans to the VA for mental health services. And my goal is to continue a dialogue with our faith-based leaders, and if any of these interventions would be helpful for them that Dr. Koenig and Dr. Pierce and I are testing, that would be great. We want to get it into the hands of faith-based leaders, particularly that chaplain intervention would be very similar to what many faith-based leaders are already doing for pastoral counseling. And one thing that is a little pet project of mine that I'm interested in doing is looking at a scale that looks at moral injuries impact on relationships, because I'm dealing in my clinic all the time with anger. And part of what people have to get through in their process, in their recovery journey, is forgiveness. And so this is a little scale. This is actually my husband, Jim Ratch, came up with a scale that on a scale of 1 to 10, what is your relationship like with self? What is your relationship like with other people? What is your relationship with your higher power? Because anybody walking in your office, they're struggling with a relationship, either a relationship in the past or current. And what I find, is that at the VA, we have to do a lot of suicide screening. And this could be a very quick way of kind of knowing where your patient's at. It's sort of like an altimeter in an airplane. If you have no relationship with a higher power, no relationship with other people, and you hate yourself, you're in a very bad place. And I would think that if you're at 0, 0, 0, you might be somebody that might be very high risk of hurting yourself. So in our chaplain intervention and in the SICPT, we use the Prodigal Son story from about forgiveness. We have appendices for each religion. And I think what's amazing about that story is that there is a loving God who wants to hold us in no matter how broken we are, and never gives up on us coming home. And I think I read a book called Tattoos on the Heart by Father Boyle, and said, in which he wrote, imagine if we all treated each other with the compassion, mercy, forgiveness, grace, and unending love that the prodigal's father had for him. So I think it's really important that when we work with veterans, that we, and when we deal with anybody in our lives, that we work on that forgiveness, we work on that grace, to have that grace with everybody that we work with, and realize that none of us is perfect. In the Japanese culture, there's an artistic ideal of wabi-sabi, that things are more beautiful in their imperfection. So if you have a pot and it has a little crack in it, you put a little gold in it. And so I think that when we're dealing with folks who are struggling with mental illness, we have to realize that we are all crackpots. We all are imperfect, and we have to care for each other through this. So in summary, I believe that we need to use a recovery-oriented, holistic, biopsychosocial, spiritual approach to suicide prevention, to the treatment of serious mental illness. Moral injuries should be recognized, as it may explain why veterans with PTSD, post-traumatic stress disorder, don't fully recover with currently available treatments for PTSD. And spiritually integrated treatments can foster collaboration between chaplains, faith-based communities, and mental health providers. And research on recognition and treatment of moral injury in veterans and civilian populations is essential. It may be part of a comprehensive, recovery-oriented, holistic suicide prevention plan. Thank you so much for your attention. This is a group of folks who helped me put together my slides. And I couldn't do anything without a team, and we all need supportive teams. And I'm just a very, very big honor to work with Dr. Koenig, who's such a remarkable light on the subject of religion and spirituality and health. This is the Veterans Crisis Line, in case you know a veteran who's in crisis. I always try to put that in my slide sets now. And this is how you could contact me if you're interested. And thanks to everybody for listening today.
Thank you, Donna. What a wonderful presentation. We so appreciate you and all that you are doing. I'm going to now open it up for everyone to just unmute yourself if you have a question that you'd like to ask Donna.
Donna, I have a question. This is Dale Fletcher with Faith and Health Connection Ministry. How would we be able to get copies of the appendices that you referenced in the cognitive behavior therapy that Pierce has developed, or you guys have developed? Where would they be able to be obtained?
Well, the cognitive processing therapy, we haven't shown that it works yet. And Dr. Pierce, I guess Dr. Koenig, we'd have to inquire with Dr. Pierce if she'd be okay with sharing these at this point. I think we're pretty open to sharing the chaplain intervention stuff, because we just want to get it out there. And the appendices are very similar for the chaplain intervention, I think, to the cognitive processing therapy, CPT. But we have all that material. Dr. Koenig, what do you think?
Yes, that's Donna, you're correct. That's a correct answer. Dale, I will get you, if you email me, I'll get you Michelle Pierce's email address. If anybody wants Michelle's email address, just send me an email. I put my email in the chat. Yeah, Michelle's been very open to sharing our SICPT intervention along with the religion appendices. So yeah, absolutely. Contact Michelle.
Okay, thank you. I'm asking because I have always believed that it's the spiritual orientation of the individual should be honored, obviously, and only when we go deep into that individual's beliefs and values and practices will there really differences be made, not a broad sweep kind of intervention.
We certainly agree with you, Dale.
Donna, congratulations for your presentation. I appreciate it very much. Could you please provide some practical examples of how spiritually integrated interventions were helpful in spiritual struggles related to moral injuries, just for us to give a better sense of the actual practice of the therapy? Thank you.
Well, I think what I've seen is that when people come back from combat, or we see a lot of military sexual trauma, and when these things happen, these traumatic events, people get really upset with God. Like, why did God let me get raped? Why did he let me, kill that little girl who wasn't really a combatant? So because God isn't behaving the way they want God to behave, it's almost like they need, and then they kind of go down this path of self-destruction. So they come back, and after having been traumatized, either military sexual trauma perhaps, or some other terrible trauma, they start drinking, they start drugging, they start really trying to kill themselves in a slow way, and they divorce themselves from God. So I've talked to some people, and they've gone so far sometimes in a direction of self-destruction. And when I show them those little TLC sheet, that 8 therapeutic lifestyle changes sheet, and I can really get a sense, as a psychiatrist, like where they are, like really quickly. And they'll say, no, I don't go to church anymore. I don't believe in that anymore. And so then I might just ask a question, well, would you want to talk to a chaplain? Because there might be a reason why you've turned away, or, there's some bad experience. And a lot of people want to go back to their father, and so I will direct them to chaplains clinically, if they're open to that. I almost see it like they need family therapy with their higher power. That dad disappointed me. He let me do this. He let me get raped. He let me get injured, or he let me kill him. And so now, how do we bring him back? And so, because ultimately, I think finding that higher power or having that resource is a source of tremendous strength and recovery. And if, I've had some success in directing people to the chaplain. I had one fellow who was really way off, lots of trouble with the law and drugs and alcohol. And, I don't pressure anybody, but with the 8 therapeutic lifestyle changes, I say, this is my approach. This is holistic. You might want to try it. He came to me and said, I took my little girl to church the other day, because it's on his list. So that's sort of a subtle way of saying, of helping people find their way back, like prodigal kids all needing to come back to the dad.
Donna, just related to this discussion in the evangelical Christianity church planting movement arena, some guys were trying to help to understand where people were in relationship to Jesus, and the initial question was asked. This is in the Southeast. Have you accepted Jesus? Well, most people answered, oh yes, when I was a kid. But they weren't getting data that was helpful to them to continue discussion. So they reframed the question is, do you feel close to God?
Right.
And that opened up everything to, oh no, matter of fact, this has happened and this has happened and this has happened. And it was really a window that opened that allowed them to gather more accurate research. And I think that same thing could apply here. Do you feel close to the God or whoever the higher power is in your religious persuasion? And that would go beyond this, well, I'm not going to church and I'm not doing this, but it gets at the heart thing. So just a thought.
No, I agree with you, because a lot of times the guys will be like, I don't want to go to church. I'm like, well, I'm not saying you have to go to church on your checklist, but is there a quiet time where you can sit and feel connected to something bigger than you? Even just being in nature and connecting to nature in a beautiful way, and seeing it as perhaps being created by a divine creator. So yeah, I think a lot of times people, they really are turned off by the what they see as the hypocrisy of church, or they had some kind of problem in their church life, or, you know, so I go to that place where exactly what you said, from that 3-point scale, it's really just about a relationship between you and the higher power. Do you have it? And do you make time in your life to spend time with that higher power, whatever that is, and that thing that's bigger than you? Because it's really hard to go through life when it's just you. After a while, you run out of yourself. And that's what I see walking in my office when there's suicidal ideation. People run out of themselves.
I have a related question. Oh, sorry. Someone, okay. I have a related question. I'm on a task force with the American Psychological Association now, developing guidelines for addressing religion and spirituality for clinicians. And one of the questions, we're fairly early in the development of this, but one of the questions is really engaging and addressing these issues for people who consider themselves spiritual but not religious, may even be atheist. And so one of the questions was sort of being curious as to the degree you've seen moral injury show up in those individuals, how you would address that, and then I guess the application of this perhaps within such things like the guidelines. I mean, that's a much bigger question, but I appreciate having been able to attend this, so we keep the moral injury piece in mind, because obviously it is applicable.
Yeah, I mean, they say that basically the soul has left psychiatry. Like, people forgot that we're spiritual beings and that just see us as a bunch of brain chemicals or behaviors. I'd say the people who are struggling the most that come in my office are often the ones that do not identify with being either religious or spiritual.
Yeah.
And so then I go back to Viktor Frankl's concept of having a sense of purpose or meaning. And I find that can be something they can relate to. So with my secular guys, I actually have a different sheet I use, which is meaning finding.
Nice.
So, you know, the religious, spiritual guys, they can say, oh yeah, I really like doing my yoga class, or I like doing my going to church, or just I have a prayer time once a day, I talk to my imam, whatever it is. But the secular guys, I talk about purpose and meaning with them. What gives you purpose and meaning? Because what Viktor Frankl said and is basically that life isn't necessarily happy, but we by having meaning in your life, happiness is a byproduct of that meaning. So what gives you purpose? Why do you get up out of bed every day and not shoot yourself in the head? What are you looking forward to? So, I mean, unfortunately, our millennials today think that money, sex, power, fame, that's going to lead to happiness. And that's who they worship. That's what they worship: money, fame, power. And so what a lot of times what people are doing when they come in your office, they're suffering from worshiping basically these false idols, if you will. And even substance abuse can become like a false idol that we, you know, anybody who uses cocaine's got to know where their dealer is, got to know where their dealer's sister is, where their uncle is, because cocaine is what you worship. And so anybody who's really gotten into 12 steps through recovery realizes that I've been worshiping this thing. We all can worship the wrong thing. We can worship our children. We could worship an abusive spouse who we keep putting up above us. So I think trying to figure out with them what's going to give you purpose and meaning. And if they have a substance abuse problem, I mean, 12 steps recovery can be very helpful for them to at least look into that. But a lot of them are like, I don't like that whole higher power thing. But if they don't like that higher power thing, that's because alcohol or drugs is still their higher power.
Dr. Ames, this is Jim Mukoyama. I am a retired two-star general. I'm a combat veteran. I have moral injury myself. I have a nonprofit, faith-based, it's called Military Outreach USA. In 2015, we published a book called They Don't Receive Purple Hearts. I want to commend you and Duke University for this presentation today. You really hit the nail on the head. I've also been at VACO. I was the chairman of the advisory committee for minority veterans. I'm at the Lovell Federal Healthcare Center, as all this is volunteer pro bono, but I want you to know that I've spoken on this for 6 years now throughout the country. And you're absolutely right. Veterans know if they have, veterans who have moral injury are being told they have PTSD, and they're being told they have traumatic brain injury. They might have shared symptoms, but they don't. Those are not the main, that's not the main problem. It's the moral injury. But when they hear me give a presentation, just like you did, all kinds of lights go off. Bells and whistles. I've had guys come up to me crying, thanking me for doing, and I send them right away. I tell them, same thing you just mentioned. You know, I mentioned about, are they registered with the VA? Are they seeing therapists? Are they talking to their chaplains? So I want you to know this was extremely well done, and you hit the nail right on the head. Thank you very much.
Thank you very much. And just an honor. I mean, I've been working at the VA for 32 years. I got into West Point when I was a girl, and much to my dad's chagrin, I didn't go to West Point. So this is my way of serving veterans, and I love the veterans. And I can't even tell you that one little slide that I showed you of Dr. Koenig's model. I will show that to somebody who's heavily addicted to drugs, alcohol, who's a combat veteran. I'll show that slide to him and say, you see how this moral injury thing that might have happened to you in combat could have resulted in the fact that you're using drugs today? And they will break out in tears. So, I mean, I know we are trying to develop, these models and these therapies, but I think there's so much to education, psychoeducation, I call it, whatever it is, but that you get that breakthrough moment when somebody realizes what they have, and then you work on their recovery. Like, we can, despite having a moral injury, despite having this thing, you can live a meaningful, purposeful life. And there's ways to give back to your community, to atone for whatever it is that you feel. So I think we have to give these people hope.
Yeah, spirituality addresses one of the major problems of moral injury, which is the loss of a sense of self-worth. They feel they're totally worthless, that nobody loves them, that God doesn't love them.
Right.
And that's where the spiritual stuff can really be effective.
Dr. Mukiyama, this is Steve Zachary. I've communicated with you in the past. It's good to see your face, sir, behind the letter. I just wanted to remark, though, to that point. I know you're trying to get this done. Thank you, Dr. Ames, for bringing it to us. But I just want to say that in the filling this in, our military members, they experience something in their life which brings about the development of these conditions. And I'm one to advocate, and I'm just learning this, that they must also experience in another way both the healing touch and the confidence of trust and an atmosphere ambiance that can bring that health back. So I just want to say it's not just about papers, tests, surveys. It's an actual face-to-face integration, as it seems to be the emphasis here, on an individual basis, unique as the soul that you're speaking to. So I just wanted to put that emphasis out there that that seems to be the direction in which we're going with this. So That's all I wanted to say.
Dr.
I
Ames.
appreciate all you folks participating in this. Dr. Ames, I'm curious about the James Griffith book that was written a decade or so ago, Religion That Heals, Religion That Harms. I've encountered even VA chaplains who tend to be more the harmful variety. And I'm wondering what advice you have for, well, this panel, and then for your teaching this throughout the VA system.
Well, I think, like I said, I see people with a variety of traumas in my office, so I can understand what you're saying about that book. And I asked I was asked by one of my focus group members, or we asked one of our focus group members who's a faith-based leader, how do you know, like, who do you refer to? And the faith-based leader said, I refer to people I know. Like, you have to really trust that person. You know, when I'm referring as a psychiatrist, I really want to make sure who I refer to is going to conduct helpful therapy, not harmful therapy. And so the same thing, I think you have to vet the chaplains that, you know, you work with, and you have to vet the therapists that you refer to, or the chaplains. I think it goes both ways. And I do agree with Chaplain Zachary that really what matters most in preventing suicide is a caring heart. And veterans know when the person cares or doesn't care. And that heart really, really matters. And especially if they're about to hurt themselves. So I had an episode, I had a veteran come in emergently one day, and I think one of the most important things we can do as therapists or chaplains or faith-based leaders is just let the person know that you care, that they matter, and you know, that they're very special. And no matter how broken they feel, how horrible they feel about themselves, they're very precious. And those words alone, when you can tell a veteran that and sincerely feel that, not just make up those words, but when you have that heart in the room, it probably doesn't matter what therapy you're doing. It's the heart that really matters, I think.
You can't fake that.
No.
Dr. Ames,